She is a researcher under Professor Mark Schlesinger at the Yale School of Public Health, and she's studying the long-term perceptions of patients that have experienced a medical error and their subsequent interactions with the healthcare system. The project and the manuscript that she'll be discussing today have been sponsored by the Betsy Lehman Center for Patient Safety in Boston, Massachusetts. Dr. Parkash will discuss the manuscript and will also touch on subsequent projects that have stemmed from the research. Welcome, Dr. Parkash. Thank you for presenting today. We will turn over the slides to you.
Okay, thank you so much for having me. So I'm going to be discussing this paper, which is on the association of open communication and the emotional and behavioral impact of medical error on patients and families. This was a statewide cross-sectional survey done in Massachusetts. As was already stated, I am associated with Professor Schlesinger, who is my mentor at the Yale School of Public Health. And my role in this study, the study was actually started well before I joined the group, but I and Dr. Dhingra were responsible for doing the qualitative assessment of the responses that were submitted, and those will result in additional papers. Well, so my slides are not moving. Any thoughts? Does anyone have any thoughts? Let's see, maybe this way. There we go. So the paper arises from this larger survey, which was published online by the Betsy Lehman Center, which assessed the financial and human cost of medical error. It was a survey, it was the Massachusetts Health Insurance Survey, in which 5,001 Massachusetts residents participated in 2017. A little over 3,000 agreed to be recontacted, of which 988 had reported medical error. And then the medical error survey was done in 2018. So the aim of the study was to assess the 5-year impact of health-seeking behaviors of patients with perceived experience of medical error. So these are not patients who were determined to have experienced medical error by physician review or any other methodology. This was just based on the patient's perception of whether they had had an experience of medical error. So the design of the study, the population that was studied was the 253 persons who reported that they had had experience with medical error, either to self or to a family member. We assessed what the role, or the paper assessed the role of open communication in that population. The comparator group was 371 people who had reported that they did not have any error experience. And the outcome was to assess what the emotional impact, if there were any socio-behavioral changes with respect to healthcare interaction and avoidance, whether it had any impact on their perception of trust in healthcare, and whether they perceived financial impact and what the financial impact was. So this paper is basically going to address just the emotional, the socio-behavioral, and trust impact of having perceived an error. And as I mentioned earlier, this was a cross-sectional recontact survey. So with respect to open communication was defined with 6 elements: whether error was acknowledged, whether error was spoken about openly and truthfully, whether the error was spoken about in a way that the patient or the person uneasily understood what had happened, whether the discussion conveyed information about the health consequences of that error, and whether the discussion welcomed inquiry about the error, and whether the discussion provided opportunities to express feelings about the error. So this is not a validated survey, but a Cronbach alpha for this was 0.8 4, if I recall correctly. So it seemed to correlate with what was trying to be assessed. This study designed, each of the elements were equally weighted, and people were grouped into whether, with respect to open communication, whether they felt that there had been no communication, whether 1 to 2 elements of those communication were felt to have been 3 to 4 elements, or 5 to 6 elements, and the analysis was done in a multitude of ways, and apology was assessed both within the model and outside of the model. The logistic regression also controlled for the financial and initial physical impacts of the error, who experienced the error, whether it was the patient or other, whether the respondent was responsible for the medical care of the patient, how long it was since the error had occurred, what the education level of the person reporting was, what the gender was, and whether apology was rendered or not. So the results, the response rate for the recontact survey itself was 41%. The overall response rate was 10% because the original MHIS response rate was 24.6%. So this is, again, as I mentioned, a report on the 253 respondents who had an experience of error, and 370 odd compared to the 370 odd respondents with no experience of error. So the characteristics of the 253 patients reporting error: 60% of them reported that the error had occurred to either themselves or to a spouse or child. 33% of the total group had experienced the error themselves. 51% reported that they were responsible for the care of the individual. 24% reported error having occurred less than a year before they were contacted, and 49% reported having perceived an error between 3 and 6 years prior to the survey. The error had occurred in the hospital in 41% of the cases, ambulatory care in 27%, and in the ER in about 15%. Again, this is a self-report, so with respect to severity of impact, 11% reported that their perception of error, the incident, resulted in death, and another 32% reported that it had significant adverse impact. 87% reported perceiving an emotional impact, of which a total of 64% reported feeling angry, 31% reported feeling betrayed, and with respect to sad, anxious, and depressed, the range was between 37 and 58%. The percentage reporting persisting physical effects at 1 year was 42%. The percentage reporting persisting physical effects at 3 to 6 years was 27%, and those reporting emotional effects at 3 to 6 years was 51%. I'm sorry. The single emotion that ameliorated over time was anger. So this displays the difference between patients who perceived an error 1 year before the contact survey, that was 60 of them, and those who perceived impact of the error 3 to 6 years out, 123 patients. And so you can see in this graph that, physical impact of the error was perceived to have reduced over time. Emotional impact also reduced over time, but you can see that a very high percentage of persons felt, like I said, 87% of them perceived some sort of emotional impact from the error, but it reduced to about 51% after 3 years. But there was not a huge amount of difference with respect to avoidance of medical care and with respect to loss of trust issues. Loss of trust in particular showed no amelioration over time. So amongst the healthcare avoidance behavior, there were three. Some patients, 57% of patients reported avoiding the doctor who was involved in care. 56% reported avoiding the facility where the error had occurred, and another 37% avoided medical care in general. And I think the last one is probably of greatest concern because this could lead to delay in diagnoses of medical issues and result in even greater harm that way. So here are some qualitative comments that the respondents made. So one patient said that I stay away from medical care. I stay away as much as possible. I use alternative resources, try and go holistic. The hardest part is cynicism and guardedness I continue to have for everyone in the medical field. I have no trust left, and they avoided medical care. They felt that the humanity is being taken out of the process. Other characteristics of the avoidance behavior was that women were more likely to be affected than men. Interestingly, persons with some college some college education were more likely to be affected than people with either higher or lower levels of education. Lower income and lower education persons were more likely to feel anxiety, feel abandoned, and to avoid all medical care after the error. Potential reasons for this that I thought was that, I think women are more commonly responsible for the care of their family members, so perhaps that has something to do with the gender difference. And I wondered about whether the lower income and education somehow correlated with the fact that this is a group of patients who already seek care only when they're sick, so they don't have a continuous relationship with a primary care provider. Of the open communication elements, the error was acknowledged in about 29% or was perceived to be acknowledged in about 29% of the cases, which is a pretty low number. A chance to ask questions was provided. It was felt that it was provided by 46% of the patients, but as you can see, in all of these elements, the respondents felt that they felt that these things were adhered to in less than 50% of the cases. 34% of the respondents felt that there was no communication whatsoever, and only 24% felt that it had complied with 5 to 6 elements of the error. So here are some responses. I guess the thing that made it worse was that there was zero communication with them, zero. Any acknowledgement of their mistake or a recognition that they need to be better listeners would be nice. So with respect to open communication, the blue bar represents those who perceive no communication, orange 1 to 2 elements, gray is 3 to 4 elements, and 5 to 6 elements is in the yellow bar. So you can see that there is amelioration of the feelings depending on how many elements are sort of, the discussion includes how many elements. And the one element that does not seem to reduce very significantly with better open or effective open communication is still anxiety. All of the other elements do seem to get better with more effective communication. With respect to behaviors, the better the open communication, the more likely the patient is to not avoid the doctor and not avoid the facility. But open communication did not reduce as much the sort of apprehension of medical care and avoiding medical care in general and it had very little impact on influencing the person's perception of trust in healthcare in general. So this is a particularly poignant response, and I'm just going to give you guys 30 seconds to read it on your own. It is very long, but it sticks with me, especially as a physician reading some of these responses. It was eye-opening. So this is actually a mother who is relating that her loss of trust in healthcare comes from having experienced an error or being present when her sister experienced an error. The sister was supposed to undergo a transplant and had been put on a respirator, and the tube came away, broke off from the respirator, and the patient got the family. The patient actually recovered and underwent her transplant. But the woman, the sister, says the hardest part is just that I no longer have trust in the medical profession. It's a general distrust of the medical profession. She has 4 children who sometimes get sick, and it's just a different level of anxiety when you can't trust anybody. You're afraid to leave the room, even when you're sitting there and you're watching them give medication or something. You're wondering, is this the right dose? Is this the right time? Is this contraindicated with something else that the child had? I mean, like I said, I don't trust anybody. I second guess everything. I only go to the doctor or even take my kids to the doctor if I absolutely have to. And emotions like this were expressed by a number of the respondents in the survey. From this paper, what emanates is that in order to ameliorate some of the effects of error on sort of emotion, there was a threshold effect in which 3 to 4 elements of communication had to be met in order to show an impact. The odds ratio is displayed there. Interestingly, in order to reduce facility avoidance, actually only 1 element of communication had to be complied with, although there was better effect with how effective the communication was. I'm not sure that the paper hypothesizes on why this difference is there. And I actually wondered whether this might have had to do with the type of error. It's actually something that we're looking into in our subsequent analysis. My hypothesis is that when an error occurs with it involves the physician is perceived as to have been primary in the error, there is a real trust relationship there, and I wonder it might be a diagnostic error where all of the discussion and decision making is going on in the physician's head, and so perhaps they perceive, you need more discussion to ameliorate the distress of having perceived an error when someone you trusted their failure or perception of failure resulted in an error, whereas potentially with respect to a facility error, those are more technical errors. Whether that might have had something to do with it, we haven't had an opportunity to analyze that data yet. It may also have to do to some extent with choice. One has lesser choice with respect to a facility, it's just larger, so maybe that somehow influences how you react to the community. These effects persisted even when controlled for apology. Apology was independently associated with reduction in impact and in avoidance behaviors after error. Greater physical or financial impact correlated with greater emotional impact from the error. And if the person perceived themselves to be the responsible for the healthcare, then there was greater emotional impact from the error. But as I stated earlier, apology and communication do not appear to alleviate and ameliorate all the effects that a patient feels from medical error. Specifically, it does not protect against persistent anxiety or loss of trust in healthcare. The limitations of the study, it's limited to Massachusetts only. A validated measure of communication assessment was not used. There are a couple of other smaller limitations. I'm sorry, I think I went back. Summary, so open communication independent of apology is associated with reduction in the emotional impact of error. And so, there might be a role to strengthening the communication and resolution programs that many of us are trying to implement. Effective open communication requires a number of elements of communication to be satisfied. So just a sort of a pro forma communication may not achieve the effects that we're hoping to achieve. It does not protect against persistent anxiety, avoidance of medical care, or trust in healthcare. And I think that that's pretty interesting because many of the CRPs that exist right now have maybe one or two interactions for discussion of medical error. I am not aware of any communication and resolution program that follows patients or their families for an extended period of time to help reduce the long-term impact of having experienced a medical error. And that's probably something that we potentially need to think about. The other thing that the survey shows is that actually CRP and apology are not as prevalent as we would like them to be. I mean, the information has existed for quite a few years now, and that only 40-some% of patients perceive that that error was acknowledged and apologized for is not great. So I think this is what we hope for, where, we hope that the patient sees things the way that we see it, and they reflect what we are seeing, but in reality, this is what it seems to be, whereas we're looking at ourselves and we have a completely different concept of what is happening, and it's a very limited amount, whereas the patient seems to perceive something much worse. And I guess I like this picture because it does say that the title is All is Vanity by Charles Allen Gilbert, and it probably reflects our vanity and our lack of attention or consideration for the patient's perception. And so that's my review of that study, and I guess I took a lot longer than I thought I would, and I'm sorry for that. So discussion, questions. Hopefully we still have enough time. Thank you.
Yes, actually, we have plenty of time. Thank you, Dr. Parkash, for the wonderful presentation. We'll open up the floor for any questions or comments, and you can feel free to unmute your mic or type in a comment in the chat, and we can relay that comment.
So perhaps we can change the screen back to the CITM screen because I don't think I can see the chat with my screen share.
Vanessa, would you be able to help with that? Otherwise, I can also read out any comments.
Yes, I'm going to do that shortly.
Thank you.
Dr. Parkash, I have a question. So the patients that were interviewed for this study were all English speaking. Do we have any information on how errors are perceived if the patient is not fluent or proficient in English, and what sort of obstacles they run into?
Yeah, there was a study from the Lucian Leap Institute some years ago, and their study showed that non-English speaking patients felt their perception of error was high. Our study, or this group, did not look at that, so I'm not sure, but I would assume that because of the association to some extent with low socioeconomic status and the lack of ability to communicate as well, that would be the impact, that they may be less satisfied with the communication, and so their perception of error would be different, or heightened, I guess is the word I'm looking for.
Sorry to interrupt. Question.
Do we have any other questions or comments?
This is Dahlia Mack. I put my message in, or my question, in the chat box, but I'm not sure if it's viewable or not. Thank you for presenting on your topic. And I'm curious about your perspective on what do you think it would take to accelerate progress. I've been in healthcare for late 20 some years, and I've been on the side of developing and implementing CRPs, but also am a family member of a patient that died from a diagnostic error a number of years ago. So I'm just curious about what your perspective is on what's it going to take to help us move more quickly. What do you think are some of the strategies?
I really think that we as physicians sort of need to let go of some of our fears of litigation. I feel that really impacts a lot of what happens. I know that the data, the research doesn't show that, but I have directed quality and safety for my department for a good period of time, and invariably, if there's a severe error, the first thing we're asked to do is call risk management. It's among the very early things that we do, and I think that heightens physician concern and sort of creates a wall between communication with the patients. I also think that we need a lot more education on how to communicate, and the more we communicate sort of uncomfortable things, not just what we know, but what we don't know, and truly get to sort of inclusive decision making, I think that's what's going to get us there. I also think one of the things that came out in reading some of these transcripts was that too often the patient did not fully register the potential downsides to the surgery or the medication, and we don't discuss those as much as we should, or make sure that the patient actually understood the risk for complications or side effects from treatment. I also think that as physicians, we downplay certain low-grade side effects that can be very intrusive on patient lives, but we just don't do that. So I think we need to have a little more education and exposure to sort of the human component of the whole process of patient care. I don't know. I guess there are a lot of other people who are much more directly involved in patient care than I am, and I was wondering if they would like to jump in. Um, what are your thoughts? You said that you thought that you have a relative who suffered a diagnostic error and passed away. What do you think, what would have worked or what did work for you?
It's it's probably a much deeper conversation, but certainly I do think that I would agree that I think the fear of litigation is something that has popped up, but also the not being able to kind of see maybe across the care continuum and understand sort of where there have been sort of potential situations of anchoring or kind of missing sort of what are the components of care that could have pointed to some different actions.
Right.
But I still think there's also an opportunity to really sort of work to partner up with patients and families to learn more and sort of understand more of those longitudinal effects that you had mentioned earlier. I don't think we have a good understanding of just, what is the ripple effect that comes from a harm that's incurred.
Yeah.
This is Natalie. I was going to say the other interesting fact too, and with that quote that you put, is just the impact that our actions have, even if there's not physical harm. So the quote that you put up was actually of a near miss,
Right.
but still had really significant impact. And I think it's important for us to sort of realize that even if something doesn't result in a death or a significant health issue, that they still might have very long-lasting emotional impact.
Right. And I think you're right about that, because I think often as physicians, we just sort of go, phew, we caught that, nothing happened. But it's actually not nothing happened. The fact that the family or the patient went through that, the emotional distress of it might have happened, I think that it's just like, I guess, I don't know. I mean, if at least I have been in situations where, we missed hitting a car or something like that. Someone came out from the side. You still get palpitations and anxiety from that. So I'm sure that this is not that different. So I do think that we need to, even with near misses, have more discussion and more sensitive discussion to sort of explore and alleviate the emotional impact on the patient and the family.
Hi, this is Chuck Pilcher. You mentioned 6 elements of the intervention. Were any of the 6 elements stronger than others in relieving fear and anxiety and mistrust?
No, actually, so the model was run many different ways, and even by doing a sub-analysis, none of them showed up as particularly high relative to the others. And I'm not sure how to interpret that.
Do you have a list of what those 6 elements are?
Yeah, so the 6 elements were, let me just get to it. Whether the error was acknowledged or not, whether the patient perceived that the error was spoken about openly and truthfully, whether the error was spoken about in a manner that was easily understood, whether it conveyed information about the potential consequences from that error, health consequences, whether inquiry was welcomed, and whether opportunities were given to express feelings about the error.
One of the things I see missing in that is what was the person or organization responsible for the error doing to assure that it wouldn't happen again. Would that help relieve anxiety?
That's actually an interesting thought. So I do know that in the qualitative component, there was a question about that, certainly for the qualitative component of the survey. So we've been a little bit delayed in being able to connect the quantitative to the qualitative because the Center for Health Informatics and Analysis imposed some more data security requirements. And so we've just gotten through those. So hopefully we will be able to do that analysis and have an answer. My recollection is that the number was too small. The patients who actually said that that type of a discussion happened and what about what the institution was going to do to prevent a recurrence, that group of patients was really very small. And so we weren't able to look at that more closely, but it's something that I'll go back and take a look at. Thank you for asking that question. It's clearly important. It's something that we need to clearly look at.
In terms of these like 5 to 6 elements, this is Kathy McDonald. I find it interesting that it looks to me like that your confidence intervals around various associations between having the 5 to 6 elements and still depressed, still anxious, etc., are smaller. So like the variation among those who got the 5 to 6 elements is less. And you were saying that your sample sizes of those who got the 5 to 6 elements there's a smaller N. So you would right? Did you just say that that's a smaller group that got the 5 to 6 elements?
Yeah, 5 to 6 elements. There were about 24% had 5 to 6 elements, but the no communication group is the largest at 34%, and 1 to 2 elements is 31%. So
yeah. So I mean, you would expect to see possibly bigger, variation in the groups that you have fewer folks in, and yet you have less variation. So it's tightening the variation as well as the point estimates being more favorable. I missed some of the session, so you might have talked about that already, but I was just interested in that finding that's says a lot. Patients can be very different, and there can be a lot of variation, and the fact that you have less variation when there's more communication.
Right.
This seems like a strong endorsement of benefits. Like there aren't people falling through the cracks. It's helping more uniformly.
Yeah, it does definitely seems to. Yeah.
Have you received feedback at this point from any health systems, like who are taking these results and wanting to do more?
We're having discussions. Truthfully, I don't know whether, the last few months have been very difficult and very unusual. We've never been through something.
Yeah.
So maybe things will pick up a little more. There was a little bit of interest right when the data came out, and then not so much.
Yeah.
And I was actually talking to Barbara Fain, who's the executive director of the Betsy Lehman Center, and she mentioned she had a meeting with a number of officials from different institutions in Massachusetts, and a lot of people seem to express sort of frustration with not being able to move forward and how to get there. So I think we need to have more discussion and put in more effort into training, although education just seems, it's the most variable element to try to influence an outcome. But I'm not sure that there is any other.
Yeah, interesting.
Oh, please go ahead. Okay. All right. The question that I had was, this was actually the first time I came upon the term communication and resolution programs. I was just curious, how prevalent are they? Are they big in Massachusetts? And is it more semantics, or are they really sort of organized differently than, say, patient affairs office or patient relations, patient advocate?
So, I mean, I think Massachusetts and, to my knowledge, Michigan and Massachusetts are sort of the true strongholds where structured communication and resolution programs have taken effect. And actually, our institution also has a structured program, so I can tell you what happens in ours. So if there is a perception of error, or even just an adverse event where the family or the patient feels, again, the clinician has to perceive this or the patient has to bring it up, we go out of our way to have a communication with the patient. And the way our system is set up, every department has a disclosure coach that you can reach out to and sort of discuss how to have that conversation so that your conversation is more effective. And I have certainly found that to be very helpful. And then our risk, part of that is that risk management gets involved. We actually set up a formal meeting with the patient and go over as much detail as the patient would like. I think the difficulty is that we tend to use those programs for high impact events. So, the data in that sense is very skewed, that it's used only for very severe sort of outcomes, or where the patient is really, really upset and bothered by whatever it is that happened.
And is there any sort of longitudinal follow-up, like you had mentioned in your presentation, as far as how the programs operate today, or are they mainly sort of focused more on specific incidents?
I think that my understanding is that Massachusetts has a fairly structured process in which several institutions participate and collect data on. So I know that from the original publications that came out from Michigan, what it showed was that actually even the number of payments or that the institution had to make went down when effective CRP programs were instituted. So that's why it was started. I don't know how much more, what, I don't know the data in sufficient detail to be able to answer that.
Okay, so if there's no further questions, we can go ahead and close out the session. I'd like to thank you very much, Dr. Parkash, and everyone for joining us today. Our next journal club is going to be on August 11th, and as always, we welcome any recommendations for those following or upcoming sessions. Thank you, everyone. We'll see you in August. Take care.
Thank you.